who sort of disappeared out will catch up. They'll just miss the intro. So anyways, I bet no one's seen a tongue like that before. A very, very special tongue, and you're unlikely to see a tongue like that again. Okay. I just wanted to introduce to you some terms that are used in dermatology, and it's a language that's useful to learn when you're communicating about what skin looks like, because it can be so difficult to be like, oh, well, there's just like this white spot. There's 5 white spots. The spots are like, 1 millimeter. It's useful to actually use a term where people actually can understand. So if you say something like macular means it's flat. So if you run your hand over it, like you can't feel any bumps, okay? But if you are going to feel something, it's going to be either a papule, which is a little bump, okay? A plaque, which is a bigger area, a bigger raised area, a nodule, which is felt below the surface, or a type of blister, which is a vesicular bullae, okay, which is fluid-filled. And then you're going to have breaks in the skin, which can be classified as erosions when they're very shallow and they look red, or ulcers when they actually break through the whole level of the epithelium, which we'll retouch again next time. They can be pustular, which means they're filled with pus, or they can look blood-filled or purplish, really, and they're termed purpura, or they can be macular areas of red, which we call petechiae ecchymosis, with this little broken blood vessels, okay? So, I mean, it is very useful to have some of that language in your pocket, okay? So one of the things that everyone likes to talk to me about is tongues, and in fact I've had a stint on the ABC radio going to talk about tongues, where I've done it twice now with Livy Gore on Sundays, where the segment is literally tongues, okay? So we do talk a bit about tongues, and then we take calls from people about tongues. So tongues are just really, really weird, okay? So you'll often find patients who do come in and be like, there's something wrong with my tongue, and because you look at tongues all day, you're really in a position to tell them whether they're normal or not. So it is important for you to be able to say, look, that's still a normal tongue, that's still a normal tongue. So people can do lots of weird things with their tongues, and one thing that is important for us to recognize well is a condition that we call erythema migrans, which probably affects about somewhere between 1 in 10 to even 1 in 6 people. So it's fairly common. It tends to pop up sort of when you're in your 20s. So not when you're really, really little. You can see it in kids, but it tends to pop up a little bit later than that in adolescence, and then you can see it throughout life. So what that looks like is essentially little swirls on the tongue that can look either red or areas of white. So there can be almost like a macular appearance where there is borders of white with erythema to various degrees in the middle. Does anybody have a geographic tongue for erythema migrans? Okay, well, you might find out tonight when you look in the mirror. So basically, it's got a few. There are areas where the papilla on the tongue can be slightly shorter and therefore look a little bit redder. Okay, so here are some other pictures. So you can have all sorts of patterns where there are areas of papillae which are shorter, and then there's areas where the papillae is actually higher and it looks differentially like an ulcer. So often people will be like, I have an ulcer on my tongue. It's usually not symptomatic, and people often point it out because they've got other symptoms on their tongue, and then they begin to be like, oh no, there's ulcers, but it might just be a coincident geographic tongue or erythema migrans. So we have a couple names for it. Sometimes we call it erythema migrans, which just really means migrating redness, okay? And that's probably is a better name for it, because you can get it on parts of your tongue parts of your mouth that are not your tongue. So you can get it on the floor of mouth, you can get it on the buccal mucosa, you can get it on the palate. But it's most commonly on the tongue, and because it changes over time, we call it erythema migrans or geographic tongue, okay? Now, it can look like a lot of other things, particularly if it's not on the tongue. So there are other things it can be, okay? And under the microscope, it actually looks like a disease called psoriasis that we see in the skin, but it doesn't act like psoriasis. So even if you put someone on psoriasis treatment, their geographic tongue won't go away. So what do we do with these patients? If you think it might be a geographic tongue, a really good test is to take a photo of it. and get them back in like 2 to 3 weeks' time and just look at it again. And what you'll find that it'll have changed, okay? Because the oral epithelium changes probably about every 7 to 10 days, and in that time you'll find that the patterns then changed. And I just think geographic tongues are so cool. Like, I like any weird tongues, non-boring tongues. And here's some fissured tongues. So you can also get like crevices in the tongue. And this can happen at any age, but it is seen probably more commonly in older people. And what it just looks like is just fissures in the tongue. People get really worried about it, and they think their tongue is like splitting or something like that. But it's actually okay, all right? What I describe geographic and fissured tongue like, as I say, it's like having curly hair, in that not everybody has it, but some people do, and it's nice, okay? So just like your tongue, and that's literally what I say. I'm like, just got a really nice tongue, just don't worry about it. Okay, the other thing that can happen is the hairs on the tongue can get really, really long, okay, and start to catch things. So it can catch stains. It might catch stains from chromogenic bacteria, so that it looks black, okay? Or it might catch something from like a mouthwash or a lolly or something and look green or blue, or it might just look really thick and white, okay? So most of the lay public think that when their tongue gets hairy like that, that it's thrush. It's not, okay? So you don't need to treat it as candidosis, because it's not. One reason why sometimes people get prescribed lozenges, and it's actually the exfoliation of the lozenge that helps to sort of bring the hairs down, and then they think, oh, my thrush is cured, but it was actually that exfoliation to just get rid of the long hairs. So it's more to do with just that they're not getting the roughage that's needed in their diet to exfoliate the top of the tongue. So we see it a lot more often, people who are not eating well, they've been a bit under the weather. And someone's going to have this case next year to tell us all about it next semester.
When you say hairs,
okay, sorry, I meant papillae, specifically the filiform papillae, so the ones, the little keratin hairs, okay? Too used to telling that to the callers. Don't worry about the hairs on your tongue. So anyways, you'll be having that conversation with lots of patients, because they'll be like, oh my gosh, my tongue is like so weird looking. You're like, well, all tongues are really weird looking. If you're looking, just stop looking in your mouth is my advice to everyone. Don't look in your mouth and let your dentist in your mouth. Okay, so obviously there is a point where a tongue is not normal, and it's really important for you to look at a tongue and be like, that is not normal. And here are some examples of tongues that are not normal, okay? So this top left area, we have a tongue that looks like it has tessellated white patches across it, okay? And there's a complete loss of papillae from sort of the anterior 2/3. You can see a little bit of papillae sort of right at the anterior portion, but it's like it's just kind of been, it's like someone's taken a paintbrush and like blurred all the papillae and made it all flat, okay? And that is very typical of a condition that's called lichen planus, which you've heard of. The second tongue in the middle, we have a completely eroded tongue, okay? So the anterior 2/3, sort of in almost like a U-shaped, the epithelium has completely thinned down, and we're seeing this sort of diffuse erythema and possibly a bit of ulceration anteriorly. But above that, so posterior to that is, again, another area that looks slightly like a plaque. Okay, and so on and so forth. The bottom left one, we can see there's there's about 7 little ulcers there. So ulcers can be a little bit difficult to recognize, because when they're very deep, they're often covered by this layer of fibrin that look yellow. So you can see that those areas that look yellow, often students will be like, oh no, it's a white patch, but it's not. It's actually an ulcer. Skin spore is covered by fibrin, okay? So what's important to ask when we see a funny patch in the mouth? Well, with anything really. I know we're sort of like segregating all your teaching into these little topics. And what you'll find is that next year we'll do it kind of differently, and that will be like, here's what a patient looks like, what could it be? But we're just presenting the information to you. So anything that we have looked at, but if you see an ulcer, one of the important things is how long has it been there, okay? And we'll chat about this next time at ulcer lecture as well. How long has that patch been there? Do you have any of these ulcer patches in other parts of your body? Other parts of your body, we are actually talking about places like the eyes and the skin and the genitals, because remember that conditions that can affect our oral mucosa can affect other types of epithelium. Have you been feeling unwell? Remember, because we were just thinking about those patients with Crohn's and stuff. Have you been feeling unwell? Okay, so really simple 3 questions. There are lots of skin problems that can manifest in the oral cavity, but we're going to talk about a limited list of them today, okay? Because I think it is important that you know these few that I'm presenting to you. I think they're important for you to know, and I would expect you to know them. What's really important is I'm going to give you lots of information today, and you have heard a lot of it before last semester, okay? So today we're kind of like going to look more at concepts rather than me just giving you lots of information, okay? And I know that you can find information really easily now. One thing to remember is that you're more often to see horses than zebras, okay? So much more commonly, you're going to see a patient who has lichen planus, okay? Compared to someone who has one of these rare conditions such as mucous membrane pemphigoid or pemphigus vulgaris. But you need to remember that these other conditions do exist. Another way to sort of look at them are conditions that arise acutely or so arise quickly and pop up quickly and then actually kind of disappear quite quickly. And other conditions where they persist, so they're chronic, okay? So that is something that we're kind of bearing in mind when you see a presentation. Again, one of our first questions we ask is, how long has this been there? Because it will really differentiate what sort of reaction we think they're having and what conditions we are considering. So just to really slim it down, one thing, again, that's important to remember is we've got lots of different forms of immunity, but we've got types which are antibody-mediated or due to a B lymphocyte becoming a plasma cell going to tissue and producing antibodies against a particular antigen, compared to those that are cell-mediated or have more to do with T lymphocytes. The reason why this differentiation is fairly important is because the diseases are treated differently, okay? Because of the way that we can, say, for example, in a cell-mediated immunity, agents that are much better at acting on T cells would be selected versus antibody-mediated immunity. We may be looking at things that are much more directed at, say, an antibody like a rituximab agent, okay? The other thing is that diagnosis is different for these two because you can measure something like an antibody, whereas you can't measure the antigen that a T cell's attacking, so remember that, okay? And we need to launch a good immune system, an immune attack, because we need to be able to recognize when something is foreign. And one thing that we are going to be realizing today when we look at these conditions of skin diseases is that it's important for us to be able to tolerate ourselves. So what we mean by that is it's important for our immune systems to realize that it's still us and that it shouldn't attack us, versus reactivity. So today we're talking about conditions where the body gets mistaken and starts to attack us. And that can look like different things depending on what that reaction is, okay? So today we're specifically talking dermatology, so we're talking epithelium and maybe just below the epithelium, so we're talking skin today. And remember that the oral epithelium consists of a basal layer which has a basement membrane upon which the keratinocytes sit, okay? And the cells of the basal layer and all the layers are bound together, okay? And they're bound down onto this basement membrane, which is essentially like a blanket of collagenous material, okay? So those particular holding together of those structures allows our skin to be intact and to be resistant to things, okay? So if there is a process which is actually attacking almost the scaffold that holds our skin together, what we get is a breakdown of epithelium, okay? So we see both forms of antibody-mediated immunity, self-attack as well as T lymphocyte self-attack in our skin. And we're going to talk a little bit about that. I've just cut this diagram up here because we can see the more specific components of what we call the desmosomal plaque, or the plaque which holds these skin cells together. I don't know if anyone's taken sewing, but sometimes to like reinforce a button, you'll actually put a button on both sides of the fabric so that the threads are not pulling through the fabric, and that's what a desmosomes is like. So it's like back-to-back buttons with little threads in the middle, okay? And then those are actually tacked down by other molecules that anchor the keratinocytes into the basement membrane, like this one that you can see on the left called BP180, which is a very popular antigen for the body to launch autoimmune attack against. So let's talk acute for the moment, okay? So again, wanting to really bring you concepts, all right? So I know I have these crazy diagrams sometimes, but it's because I'm trying to communicate the confusion that I've had to figure out in my brain to you so it's easier. So when I was going through dental school, we were described this continuum of conditions that were called erythema multiforme, that continued on a spectrum of severity when erythema multiforme, Stevens-Johnson syndrome, and toxic epidermal lysis, epidermal necrolysis. Okay, but what we actually know now is that there's two spectrums with overlapping features, and they're actually different diseases. Okay, so it is important to describe that, and they're not a complete continuum. And we see things fairly differently from the dermatologists because they look at the skin where we look at the mouth. And what's important to discuss is that for us, in the mouth, all these conditions, whether it's erythema multiforme minor or major, or Stevens-Johnson syndromes or TEN, they all look the same in the mouth. Okay, so what we see is that the skin's gone, all right? So like the skin's just gone, it's all fallen off. And we see completely bare some mucosal tissue, okay? Kind of like that young gentleman I took a picture of on the wards on the far right, okay? So just like literally it's gone, okay? Cutaneously, these two conditions are quite different, okay? So with erythema multiforme, it tends to be less severe than Stevens-Johnson syndrome and TEN. And the cutaneous, the skin presentation is very typical in that they have these targetoid lesions. So these skin lesions or these cutaneous lesions that look like a target. So it's got a sort of specific red center like a target, okay? And that's very typical of EM. In the mouth, there's two classifications. We don't see the EM minors because EM minor means it's only on the skin, not on mucous membranes, but EM major can affect mucosal, the mucosa. It's typically triggered by something like the herpes virus, so HSV1 is the most common trigger, and it happens usually a week after the cold sore. So some patients actually experience this really scary thing like multiple times, and sometimes it's associated with the fact that they're getting HSV1 reactivation. What else was I going to say about this? So it's very typical in that you've got these sort of blood-crusted lips and looks really scary, but they actually can get better fairly quickly. Okay. Stevens-Johnson syndrome, on the other hand, is a bit different because it's medication-related, and unlike EM, which primarily affects younger people, Stevens-Johnson syndrome can affect anyone, even someone older, and it may be related to the fact that people are often introduced to drugs later in life. Okay. And they get this, a different type of rash. So they get a macular, so it could be like a flat rash that looks purple, but it might also erupt into blisters, okay? And then just like the mouth, the skin falls off, okay, like a burn. And if it's affecting and these are some of the drugs that are most common. Most of them are antibiotics, but it can occur also with things like anti-epileptic drugs. So with Stevens-Johnson syndrome, we call it Stevens-Johnson syndrome if less than 10% of the body surface affected, but a lot of these patients do have that same appearance in the mouth, okay? And so this is this gentleman who's started getting this really strange sort of sensation around the lips, and you can see the vesicles are starting to form. And then within a few days, it's erupted. So really interesting because the antigen that the body's just decided to mistaken might be in common with the skin and the mucosa, or it might just be the oral mucosa, which just only shows up in the mouth. In this particular gentleman, it seems to be some sort of antigen that's found in the transit between the mucosa and the cutaneous skin. So it's really interesting. It seems to be specifically around that transition both in the nose and the lips. And TEN is that condition which is affecting larger portions of the body, and it's very, very scary, and it can be fatal. Okay, so that was an acute presentation, so rapidly arising, and needing acute care, needing to go to see someone very acutely. We're going to talk a bit, just really briefly about lupus. Lupus gets mentioned again next week. But lupus, we're not going to talk about lupus, but what I want you to really think about with lupus is putting it in the lichen planus bucket, okay? So lupus in the mouth really looks and behaves just like lichen planus. And it's the reason why we might call it lichen planus is because the patient also has cutaneous lupus, or they have other forms of lupus. Probably the main difference is lupus likes the lips, so that it likes to come outside onto the lips, and that can be very tricky to treat. But lichen planus can do that too. Okay. And probably affects slightly younger people as well, 20 to 40 as opposed to lichen planus is 50 plus. Yeah?
Is the way to distinguish the erythema multiforme from Stevens-Johnson, is it biopsy?
Okay, yeah, so that's a good question, and I apologize I didn't answer that well because I should have really gotten that to it. The difference, the way to distinguish them is their cutaneous presentations, okay? So erythema multiforme, so it's, when you take a biopsy, they look very similar, which is just that all the skin is dying, okay? So all the skin cells are just exploding. So not histopathologically, they look the same. But what they do, what helps to differentiate them is their cutaneous findings. Okay, so erythema multiforme are targetoid lesions, whereas SJS is a more of a macular papular rash. So the dermatologist will not mistake these two because they're looking at the skin. But for us, they look really similar. And I've had some tricky cases because I often get called to the ones that are mouth only, so that's really confusing because they look the same. And the way I tend to differentiate them is that we have to find the history to see if we can actually find out what's triggered it. Yeah. But if it's occurring just in the mouth, that's better than it having been all over the cutaneous skin. Okay, so I really want to dive into these important concepts that I want you guys to get your heads around, which is we're going to contrast these three diseases. We're going to contrast pemphigus vulgaris, mucous membrane pemphigoid, and oral lichen planus. Okay, so remembering that we can get different types of attack to different components of the epithelium. So pemphigus, and all the different types of pemphigus, affects these desmosomes, or the little proteins that latch the skin cells together, okay? So basically that stickiness of the skin cells holding together is getting attacked by antibodies, and therefore the skin cells are splitting apart, okay? Which is what's responsible for a lot of what we see both under the microscope and clinically. Pemphigoid attacks any component that binds the keratinocytes down to the basement membrane, okay? And so remember, we've blown this up really big, but we're talking about microns, okay? So different antigens in that area. Whereas if you can think about lichen planus can attack anything in the epithelium to a basement membrane zone, okay? And we don't know what's being attacked because we can't tell what the T cell's attacking. All we see is that there's just lots of T cells sitting underneath the epithelium, and the epithelium is dissolving. All right, so Yannis is going to talk to you a bit about microscopic features of lichen planus, but the key is that you've got T cells, okay, you've got T cells sitting underneath the epithelium, and the epithelium's being attacked, okay? So because we don't know exactly which antigen it is, it's probably, firstly, why we see lichen planus more often, and secondly, why lichen planus is a very heterogeneous disease, okay? Okay, let's talk about diagnosis, because let's talk about how we can tell what each of these conditions are. So obviously we put together the picture of what the patient looks like and what we can see when we take little bits of them, including bits of skin and bits of blood, all right? So I think you've had a little bit of teaching around different types of lichen planus. We like to box things. There's like this philosophy of some people are like lumpers and like to just put everything in one box, and some people are like splitters and like to categorize everything. I'm definitely like a lumper, so I'm like, oh, lichen planus. But many people like to split and categorize and subcategorize things, okay? Or lichen planus, I've just given you some descriptions here. So what I usually describe to patients is we have attack of the skin by the body, and the body responds, that patch of skin will either respond by getting thicker and looking wider, okay? Or it can get thinner and look redder if it gets thinner, or it can break and create an ulcer, okay? So if you think about it like that, we can see all those different processes, and sometimes we can see all of those processes in one patient. So there's areas that are a bit wider, little areas that are a bit redder, and areas of ulceration. So it's not that, probably the only type of, those two on the right, the reticular and papular, patients often have those in isolation, but they very rarely have only ulcerative disease or only erosive disease or only plaque-like disease. They tend to have some of those other features, okay? In contrast, remember that vesicles and bullae are different types of blisters depending on how big they are. So vesiculobullous conditions, or blistering conditions, look a little bit different, but sometimes it is hard to tell which one they are. And sometimes you might see that blister, like that top left, where we've actually got a blister, and it's bleeding into there, so it looks like a blood blister, but it's not. You can tell it's not just someone's bitten their lip. It is a blister that has been bled into. But sometimes you don't see the blister. You see it after the roof has broken and you see an ulcer. Okay, which is what's in most of those other photos. But that bottom right photo can show you just that friability of the skin peeling off the bottom layer, all right, because it's being attacked. Now, I want to also introduce you to the concept of discriminative gingivitis. So the term discriminative gingivitis means a gingivitis that is not related to plaque, okay? So it's not a plaque-induced gingivitis. And when we use the term discriminative gingivitis, it itself is not a diagnosis. It's very much analogous to me saying something like ulcer, okay? So if I'm like, there's an ulcer there is a discriminative gingivitis there. So there is there's a gingivitis there that does not appear to be plaque related, okay? So that's how we use the term, because discriminative, or peeling, where and the gingiva can be peeling off, okay, that's discriminating, or it can just look really red because it's eroded, okay, or it might have areas like that top right photo where there's a bit of little striae, okay, or little bits of reticulation, and so you can see almost this like spider web around it with a little bit of background erythema, despite there not being, that obvious plaque, accompanying plaque and swelling and marginal erythema. That's not there at all. This person seems to be cleaning well, and yet there's erythema. Okay, so this description of discriminative gingivitis is actually common to quite a number of conditions, including erythema multiforme, lupus, the conditions that we're talking about now. So lichen planus, immunobullous conditions, pemphigus and pemphigoid. And so you just need to bear that in mind, okay? So when we see a discriminative gingivitis, we actually are thinking, what could this be, depending on what's happening. We also like to take bits of human, and we might send them for a really basic test, which is a histopathology. So the piece, a bit of human is taken, okay? That is put in formalin so it can be fixed. That is then put in a block of wax, okay? Or paraffin, and then it is really thinly sliced and put on a slide so we can shine light through it and look down a microscope where it's enlarged, okay? So it's essentially what happens to them. We often use stains as well. In this case, it's H&E, so hematoxylin and eosin, where we can actually demonstrate some cells, and we can use other stains to show other types of things as well. We might do what we call direct immunofluorescence, okay? So what we do here is we can't fix the tissue. We need a bit of human that's still fresh, because the fixing doesn't let us do the immunofluorescence, okay? So we need to get another piece of tissue or split our sample and have that tissue, usually it's frozen immediately, and then cut while it's frozen, okay? And then what we can do is actually put different types of antibodies on it, and look and then attach a fluorophore, so like a fluorescent molecule that attaches to antibodies that will show us where the antibodies are getting stuck. Okay, so that is in the patient's tissue themselves. We can also do what we call indirect immunofluorescence, okay, which is when we use the patient's blood or the patient's serum, okay? So the patient's blood without the cells, okay? And what we can use is another type of tissue, such as a bit of monkey esophagus or a bit of other human or a rabbit or something. And we can actually put the patient's blood on that tissue and see where it attaches. Okay, so we put the patient's blood on it, and we know that the antibodies in the patient's blood are going to attach somewhere. And then we get another antibody with a fluorescent balloon, which is a antibody to human, okay, human. And so it goes, where's the human? And it attaches to any human antibodies that are stuck there. And then we look at it and we see a pattern like that, okay? So those are the few different things that we can do to help us to get a diagnosis for a patient. It sounds really tidy, but it's actually not quite so tidy because, for instance, this test, the serum test, is not quite so sensitive for some conditions because sometimes the antibodies are not circulating in high numbers. It's more of a localized thing. But for pemphigus, it is fairly common. The other thing we can do, so with these, all we're saying is that we know there's an antibody that's getting stuck in skin, okay? Whereas we don't know exactly which molecule is being attacked, but we can use an ELISA, which some of you might have played with in your undergrad, which is actually we're using a known antigen, and we're seeing if we get any reactivity from the patient's serum of that known antigen, and then we use another layer to show a fluorescent balloon of what we see. Okay, so those are the tests that we can use to actually get to our diagnosis, usually more relevant when we are trying to diagnose an immunobolus disorder, so differentiate between pemphigus or different types of pemphigoid. Okay, so let's talk about pemphigus again. So just reiterating that, so the tongue that I showed at the beginning, that's a pemphigus patient. Okay, so this patient, we can see that when you look at their epithelium in the H&E, it's like the break of the skin is really messy, like it's got like little bits that are breaking around it, okay? And so what we actually term that is acantholysis, or breakage within the epithelium, okay? And sometimes you see these little lone keratinocytes that have been forgotten, okay? And they look like tombstones, so sometimes we call it tombstoning, and little bits of dead cells, right? When we look for antibodies, remember, because the antibodies are attacking the junctions between the epithelial cells, we're going to see antibodies sitting around the cells, okay? Or a pattern that sometimes pathologists call chicken wire, the chicken wire pattern, okay? So it's showing us that there is a intercellular fluorescence, okay? So between the cells. Let's now contrast that with mucous membrane pemphigoid. So just to clarify, the term pemphigoid is used quite broadly to describe any disease that results in splitting of the epithelium from the underlying tissue. And there's lots of different subcategories of it. But anything that involves the oral mucosa, we've blanketed to call mucous membrane pemphigoid. And usually the antibody involved is an IgG. Sometimes if it's an IgA, we call it linear IgA disease. It doesn't matter. Anyways, pemphigoids, mucous membrane means it's a subepithelial blistering condition that affects the mucosa. And so what we can see here is the split between the epithelium. It's a subepithelial split, so it's underneath the epithelium, and it's a lot tidier. So you could actually feel like you could draw right underneath that epithelium, and it's very clear that there's no epithelium left along the connective tissue. And with our immunofluorescence, okay, now they've used like some DAPI to just show where the nuclei are, but what we can see is like this green line. So it's a linear pattern, a subepithelial fluorescence, okay, linear subepithelial fluorescence. Okay, whereas lichen planus, remember that it can attack anywhere. we can still see a split, but sometimes we don't, okay? But some of the key features are you can see this almost like purple dots underneath the epithelium. That's our band-like area of lymphocytes, okay? And when we look at the epithelium, what we see is that the epithelium is just breaking down. So we might see things like what's called vacuolar degeneration. So basically the keratinocytes are getting killed off, so they actually just like expand and blow up, okay? You might see little bits of dead cells, which are called civet bodies, okay? And because you're busting up so usually when you have the ret pegs or the ret ridges, there should be like this nice undulation, but if you're busting up all the keratinocytes, they become like little, they become sharp, like a sawtooth, okay? So Yanis is going to go through that again, but the way to conceptualize is I don't want you guys like memorizing this list of histopathological features. I want you to be able to say what we see is a result of T-cell inflammation attack against the epithelium, and therefore we see, bits of dead cells, and we see that the epithelium is basically breaking down, okay? So I want you to be able to understand it, not just list off these, if you say like, oh, civet bodies, then I'm like, well, what is that? I'd much rather you say bits of dead cells, because I know you understand it, okay? With autofluorescence, we shouldn't see any antibody autofluorescence, because then it's a different disease. However, sometimes we see some non-specific fluorescence against fibrinogen, okay, which is not specifically a positive antibody reaction, but something that we can see in types of inflammatory conditions. Okay. What I'd like to talk to you about now in just these next few minutes is what's so bad about these conditions, okay? So why can't we just why do we even have to diagnose them properly? Because if they're is it really just academic? No, it isn't, okay? So let's talk about pemphigus vulgaris first, okay? Now, the worst things that happens with pemphigus vulgaris is extension, okay? So what I mean by that is that if you don't start treating it, it can get worse and go from, it usually starts in the mouth, but it can go to other parts of your body and start to just peel your skin off in all parts of your body, and also your mucous membranes, okay? And they've got a really big cohort of patients in Italy, and also I feel like in Australia we often diagnose much earlier, so we don't have as many gory photos, but here is mucous membrane involvement, okay? So it can go down nasopharynx as well as the genitalia, and it can go to the eyes, okay? So this used to be a disease that was invariably fatal before we had steroids. People would die because they just completely became dehydrated, couldn't eat, and it would be fatal, but it is no longer the mortality is definitely not as high as it used to be, but because they need to be treated very aggressively, some of the side effects of those medications are more likely to be the responsible for remaining mortality rates. The other thing is because they tend to be diagnosed at older ages, the ability of that person in terms of their other comorbidities might be relevant to their survivability. So the way that we treat these patients is we call it a top-down approach, okay? So it means that we hit them with a sledgehammer, okay? We have to treat them very aggressively. They go on high doses of prednisolone almost immediately, and it's only when their disease starts to get a bit more under control that we can decrease the prednisolone and begin to introduce a steroid-sparing agent. Sometimes they still don't get better, and they might need to get onto more complex agents, like we talked about last time, rituximab, which is a monoclonal antibody against B cells, okay? So just to take out all their B cells. So I'd probably say at the Royal Melbourne, about maybe 25 to 30% of pemphigus patients need to have rituximab. And they're treated long-term, so that's how we get to know them all really well, because we just see them for years. Even though they may not be sick, we have to be careful with them because it is a disease that can go into remission but then relapse quite aggressively, and we want to make sure that we're keeping an eye on them. Okay, so with mucous membrane pemphigoid, we're not so much worried about the high rates of mortality, but we're worried about something else, and that is scarring, okay? And this is because of where it attacks. So remember we talked about epithelium and how if it goes into the subepithelium, we're more likely to get scarring, okay, which is like what happens with Crohn's as opposed to ulcerative colitis. And what can happen is it can affect different parts of mucosa, okay? And it can lead to scarring. And that is definitely very, very relevant in the conjunctival mucosa. So this patient on the left here has what we call a symblepharon. So that means there's been inflammation in the mucosa. So it's, I mean, you guys, we don't look at eyes all the time, but what we should actually see there is like a nice ditch of the conjunctiva, okay? And that lower eyelid should be very mobile. But you can see that on that left, the left picture, there's actually one section where the conjunctiva is actually fused, okay? And that one on the far right has become like one continuous sheath, and the one in the middle has actually gone to the point where they can't blink properly, and now so it can lead to blindness. Okay. Now, thankfully, not all types of mucous membrane pemphigoid are scarring, and some patients have it only in the mouth, some patients only have it in the eyes, some patients have it in the genitalia. There can be a mix. Okay. And we think that the more common, so if we just look at these different antigens, the most common is BP180. But if it goes down lower to collagen 7 or even laminate 322, if it goes lower down in the basement membrane, those patients seem to be the ones who are more likely to get scarring disease. And we can see that in the mouth as well. So this is really good. This is a good example because you know exactly what a sulcus should look like, okay? So again, we should see a really nice ditch up around the labial to the labial mucosa and the vestibule. There's like no vestibule, okay? So the mucosa is literally coming out from the neck of the teeth. And so you can imagine how difficult it is for this patient to clean, how difficult it is for their periodontist to clean or you to clean, and how difficult it would be to rehabilitate them prosthetically, okay? Because there's like literally, how are you gonna do that? There's like, and the other issue is not only does it do that to me because it goes down the gingiva, so we're like losing bone, really, really difficult condition to treat when this happens. We try to keep the teeth as long as you can, just get their hygiene really good, really, really challenging, much better if we can get them earlier. This lady was just a terrible patient. She didn't listen to anybody, she didn't refuse all treatment. We finally got her on something, and she hasn't worsened, but she's had a lot of scarring. Not all of them scar, so this gentleman doesn't scar, but he's got fairly active disease. Another curious thing is when they've got deep ulceration, it actually tends to be less painful. So pemphigus patients, it's very, very painful, whereas mucous membrane patients, it is painful, but they're much more likely to say, oh, look, it doesn't bother me, which is, you look at it and you're like, really? And this gentleman, his main thing is he's like, oh, I have to drive all the way out to see you guys again. That's his main sort of grumble, not really the fact that his skin's falling off. So we need to bear that in mind. So with this condition, some patients need to be treated top down. They need to be treated very aggressively. But others can be treated bottom up. So what that means is that we can be fairly conservative with them as long as we know they're not in the scarring category. We can just use things like topical corticosteroids, local debridement, oral hygiene, more sort of gentle immunomodulators rather than really heavy-handed immunosuppressants. So different approach than pemphigus. And this is why it is really important to differentiate between these diseases, because they're not treated the same. Okay. With oral, yeah.